Heart disease does not always announce itself with a dramatic, unmistakable event. In most cases, it builds silently over years, inside the walls of arteries, in the electrical system of the heart, in the small vessels that supply the fingers, the earlobes, and the gums, and it sends signals long before it produces a crisis. The challenge is that most of these signals look like something else: indigestion, fatigue, aging, dental problems, a sleeping difficulty, a swollen ankle. They are dismissed, attributed to other causes, and managed symptomatically while the underlying cardiovascular disease progresses unaddressed. According to the American Heart Association, cardiovascular disease is the leading cause of death globally, and early detection and risk reduction remain the most powerful tools available for preventing the events, the heart attacks, the strokes, the sudden cardiac deaths that claim so many lives that appropriate recognition could have prevented. This video covers 15 warning signs across the full range of what heart disease looks like before it produces a crisis, from the familiar to the profoundly unexpected. Several of them will surprise you. This video is for educational purposes only. These signs have many causes other than heart disease. Any sign that is new, persistent, or concerning should be discussed with a physician. The diagnostic tests for heart disease, ECG, echocardiogram, stress test, coronary calcium scoring, lipid panel, and blood pressure assessment are available through any primary care physician. Sign number 15. Chest discomfort, pressure, or heaviness, a sensation in the center of the chest that can feel like a heavy weight, a squeezing pressure, or a band tightening around the chest, and that may radiate to the left arm, jaw, neck, or back. This is the most recognized heart disease warning sign, and it appears last on this list, not because it is the least important, it is one of the most urgent, but because it is the sign most people already know about. According to the American Heart Association, most heart attacks involve discomfort in the center of the chest that lasts more than a few minutes, or that goes away and comes back. It can feel like uncomfortable pressure, squeezing, fullness, or pain. For seniors, the pressure quality may be mild enough to be confused with indigestion, and the absence of the expected dramatic pain leads many people to delay calling for help. Any chest sensation that appeared without a dietary or physical cause, that lasts more than 5 minutes, or that recurs, warrants calling emergency services immediately. Sign number 14. Shortness of breath, difficulty breathing that appears during activities that previously required no effort, or breathlessness that arrives at rest or wakes a person from sleep. According to the American Heart Association, shortness of breath can occur with or without chest discomfort, and it is one of the warning signs of a heart attack. When the heart's pumping function is impaired by coronary artery disease, by heart muscle weakness, or by valve disease, blood backs up into the pulmonary circulation and impairs normal gas exchange in the lungs, producing the breathlessness that seniors may attribute to deconditioning, lung disease, or weight gain. A senior who finds that climbing one flight of stairs now leaves them breathless when it previously did not, or who wakes at night unable to take a deep breath and needs to sit up to feel more comfortable, has a symptom pattern that warrants cardiac evaluation alongside any pulmonary assessment. Sign number 13. Extreme fatigue, a bone-deep exhaustion that appears disproportionate to physical activity that does not improve with rest, and that has developed over weeks or months without another clear medical explanation. According to the AHA, unusual fatigue is among the warning signs that women in particular experience before a cardiac event. The heart's reduced output in early cardiac disease means that less oxygenated blood reaches the muscles and brain, producing the specific fatigue of reduced cardiac reserve, present even at rest, worsened rapidly by minimal exertion, and different in quality from the tiredness of poor sleep or physical overwork. A PubMed-cited study found that 70.7% of women reported unusual fatigue in the weeks before their heart attack, making it the single most prevalent prodromal symptom. Any fatigue that is qualitatively different from a person's usual tiredness and that appeared over weeks without another adequate explanation deserves cardiac evaluation. Sign number 12. Heart palpitations, or irregular heartbeat. The awareness of the heart beating too fast, too slow, fluttering, skipping, or pounding in the chest, occurring at rest or without the exertion that would normally produce an elevated heart rate. Palpitations have many benign causes: caffeine, anxiety, dehydration. But in a senior over 60 with cardiovascular risk factors, new or worsening palpitations deserve an ECG at minimum, because atrial fibrillation, the most common cardiac arrhythmia, produces exactly this symptom and carries a 5-fold increased risk of stroke when untreated. According to the AHA, an irregular heartbeat that feels like a flutter or a racing sensation is among the warning signs of cardiac disease. A senior who notices their heart behaving irregularly at rest, particularly if accompanied by any dizziness, breathlessness, or chest discomfort, should contact their physician that day for an ECG rather than waiting to see if the sensation passes. Sign number 11. Swelling in the feet, ankles, or legs. Bilateral pitting edema that is worse at the end of the day, that leaves a visible indentation when pressed and held, and that has developed without a clear venous, kidney, or dietary explanation. The thumbnail's right panel, showing a physician pressing a finger into a swollen ankle and observing the characteristic indentation of pitting edema, illustrates this sign directly. When the heart's pumping function is reduced by heart failure or significant valve disease, blood accumulates in the venous system that should be returning to the heart, building hydrostatic pressure that pushes fluid out of the capillaries and into the surrounding tissue, particularly in the feet and ankles during the day, and in the lungs during sleep. According to Cleveland Clinic's heart failure overview, swelling in the legs, ankles, and feet edema is one of the cardinal signs of heart failure. The pitting quality, the indentation that remains for several seconds after finger pressure is released, is the clinical hallmark that distinguishes cardiac edema from the non-pitting edema of lymphatic obstruction. For any senior with new bilateral ankle swelling who also has any breathlessness or fatigue from this list, a cardiac evaluation should be part of the same assessment. The practical pitting edema test that anyone can perform at home and that the thumbnail directly illustrates requires only a thumb. Press the pad of the thumb firmly against the inner ankle or the top of the foot and hold for 5 to 10 seconds, then release. A normal response: the tissue springs back to its original shape within 1 to 2 seconds. A pitting response: the indentation from the thumb remains visible for several seconds or longer before slowly filling back in. The longer the indentation persists after the pressure is removed, the more significant the degree of fluid accumulation in the tissue. A senior who finds a clear, persistent indentation when they press their own ankle each evening, particularly one that is better in the morning after lying flat all night and worse by evening after being upright, has the classic gravity-dependent pattern of cardiac or venous edema that warrants the evaluation to determine which of these causes is responsible. Sign number 10. Dizziness or lightheadedness, particularly when standing quickly, when exerting, or when accompanied by any other sign from this list. Cardiac causes of dizziness include reduced cardiac output from heart failure or significant arrhythmia, orthostatic hypotension from autonomic dysfunction, and aortic stenosis, a narrowing of the main heart valve that restricts blood flow out of the heart. The triad of exertional dizziness, chest discomfort, and breathlessness is the classic presentation of aortic stenosis and warrants urgent cardiac evaluation. For a senior over 70 who develops new dizziness on standing or with mild exertion without another blood pressure or medication explanation, an echocardiogram that assesses cardiac valve function is one of the most important diagnostic next steps. Sign number 9. Cold sweats, appearing suddenly without physical exertion, room temperature, or fever to explain them, particularly when accompanied by nausea, chest discomfort, or unusual fatigue. According to the AHA, cold sweats are specifically listed alongside chest discomfort and nausea as heart attack warning signs. The thumbnail's left panel, showing a woman in distress with visible perspiration, holding her chest and arm in discomfort, illustrates this sign: the cold, clammy sweat of sympathetic nervous system activation that accompanies cardiac ischemia. The quality distinguishes it from exercise sweat or menopausal flushing. Cold sweats are clammy and cool rather than warm, and they appear without the temperature or exertion context that ordinarily produces sweating. Sign number 8. Leg pain when walking that improves with rest. Specifically, a cramping, aching, or heaviness in one or both calves, thighs, or buttocks that begins reliably after walking a certain distance and that resolves within a few minutes of stopping to rest. This symptom, called claudication, from the Latin for to limp, is the cardinal symptom of peripheral artery disease, and peripheral artery disease is a direct manifestation of the same atherosclerosis that causes coronary artery disease. According to Dr. Joel Kahn's Integrative Cardiology Overview, calf pain when walking might mean clogged arteries, and this symptom requires evaluation without delay because peripheral arterial disease can precede the diagnosis of coronary heart disease. A senior who has begun stopping to rest their legs during a walk that they previously completed without difficulty and who attributes it to muscle weakness or aging may be experiencing the reduced arterial blood supply of peripheral vascular disease, and finding peripheral vascular disease warrants immediate coronary artery disease evaluation as well. The ankle brachial index, a simple, non-invasive measurement that compares blood pressure at the ankle to blood pressure at the arm, is the standard first test for peripheral artery disease and can be performed in a primary care office in under 5 minutes. A ratio below 0.9 indicates significant arterial narrowing in the leg vessels. According to cardiology data, individuals with peripheral artery disease have a 2 to 4 times greater risk of heart attack and stroke than those without it, because the same atherosclerotic process that narrows the leg arteries has almost always been simultaneously narrowing the coronary arteries that supply the heart. Claudication is not a leg problem. It is a systemic vascular problem that reveals itself in the legs because the walking demand exposes the reduced blood supply that is also present, more silently, in the heart's own vessels. Sign number 7. Snoring, witnessed apneas or waking unrefreshed. Loud snoring accompanied by gasping, stopping breathing observed by a bed partner, or consistently waking after what should be adequate sleep, feeling as tired as when going to bed. Obstructive sleep apnea is a powerful and independently recognized cardiovascular risk factor. According to the AHA, obstructive sleep apnea is associated with hypertension, atrial fibrillation, coronary artery disease, and heart failure, all of the major cardiovascular diseases. The mechanism: each apnea episode produces a surge in sympathetic nervous system activation, a spike in blood pressure, and an episode of hypoxia, low blood oxygen, that cumulatively produces vascular injury, endothelial dysfunction, and sustained hypertension throughout the day. A senior whose partner reports loud snoring and pauses in breathing during sleep should request a sleep study because identifying and treating sleep apnea is one of the most impactful cardiovascular risk reduction interventions available. Sign number 6. A persistent nighttime cough. A dry, sometimes productive cough that appears predominantly when lying flat at night, that improves when sitting up, and that has not been explained by respiratory infection, allergy, or a new ACE inhibitor medication. This specific pattern, a cough worse when horizontal and improved when upright, is the posture-dependent cough of pulmonary congestion from heart failure. When the failing heart cannot adequately pump blood forward, fluid accumulates in the lung tissue, and the redistribution of this fluid, when lying flat, stimulates the cough receptors of the lung. The practical distinction from a respiratory cough: a respiratory cough is worse in cold air, in the morning, or with speaking, and is accompanied by phlegm or nasal symptoms. The cardiac cough is specifically postural, worse when flat, better when sitting up, and may be accompanied by the breathlessness and ankle swelling of early heart failure. Sign number 5. Loss of appetite and nausea. A persistent reduction in interest in food or a low-grade queasiness that has appeared without a digestive explanation, particularly in the context of any other sign from this list. According to the AHA, nausea and upset stomach are warning signs of a heart attack, particularly in women. Beyond the acute cardiac event, early heart failure can produce reduced appetite and nausea through liver congestion from backed-up venous blood, through the reduced perfusion of the gut that impairs digestive enzyme production, and through the systemic inflammatory cytokines generated by the failing heart. A senior who has lost interest in eating over recent weeks alongside increasing fatigue and any breathlessness or ankle swelling has a symptom cluster consistent with decompensating heart failure that warrants same-week cardiac evaluation. Sign number 4. Erectile dysfunction in men or reduced sexual function. The new development of erectile dysfunction in a man with no prior history of it, particularly in the absence of a new medication or psychological stressor to explain it. Erectile function depends entirely on adequate blood flow to the penile vasculature, the smallest and most sensitive arteries in the male body. These arteries are among the first affected by the endothelial dysfunction and early atherosclerosis of cardiovascular disease, producing erectile dysfunction that may precede significant coronary artery disease by years. According to multiple cardiology and urology guidelines, new-onset erectile dysfunction in a man with cardiovascular risk factors is an independent cardiovascular risk marker that warrants proactive cardiac evaluation. The penile arteries as a sentinel for the coronary arteries. Any man over 50 who develops new erectile dysfunction without an obvious medication or psychological cause should specifically discuss cardiovascular risk assessment at the same appointment as the urology evaluation. The penile artery is approximately 1 to 2 millimeters in diameter, one of the smallest arteries in the body. The coronary arteries that supply the heart are approximately 3 to 4 millimeters in diameter. Because plaque builds in smaller arteries earlier and more severely than in larger ones, the penile vasculature experiences the consequences of atherosclerosis before the coronary vasculature reaches the same degree of narrowing. This means that erectile dysfunction from vascular causes typically precedes a cardiac event by 3 to 5 years in many men, making it one of the earliest detectable vascular signals available. A cardiologist who evaluates a man with new vascular erectile dysfunction will order a stress test, a coronary calcium score, and a full lipid panel, not simply a phosphodiesterase inhibitor prescription. For a man who has been prescribed these medications for erectile dysfunction without any concurrent cardiovascular workup, the cardiac conversation has been omitted from an evaluation that specifically required it. Sign number 3, bleeding or inflamed gums, tooth loss, or chronic periodontal disease. According to CNN's Cardiovascular Signs Overview and today's RDH Clinical Review, studies have shown that tooth loss and inflamed gums, periodontitis, are markers of heart disease. The mechanism is bidirectional. The same systemic inflammation that drives atherosclerosis also impairs the immune response that protects gum tissue from bacterial infection, and the bacteria that colonize diseased gum tissue can enter the bloodstream and directly accelerate endothelial inflammation in blood vessel walls. A senior with long-standing periodontal disease who has multiple risk factors for heart disease but has never had a cardiac evaluation has a risk profile that specifically warrants the conversation with their physician about coronary artery assessment. Gum health and heart health are not independent. They are connected through the inflammatory and microbiome pathways that govern both simultaneously. Sign number 2. A diagonal crease in the earlobe, a visible fold or wrinkle that runs diagonally from the tragus, the small cartilage bump in front of the ear canal, toward the outer lower edge of the earlobe, and that is present on one or both ears. This sign is called Frank's sign, named after the physician who first described its association with coronary artery disease in 1973. Over 40 studies have demonstrated an association between this feature of the ear and an increased risk of atherosclerosis. Frank's sign is associated with greater coronary artery disease risk in the general population, independent of traditional risk factors such as smoking, aging, diabetes, and high blood pressure. According to the 2024 PMC case report on Frank's sign in cardiac disease, the sign should be regarded as a routine cardiovascular clinical examination that can be effortlessly applied for screening to suspect the presence of ischemic heart disease. The practical self-examination: look at both earlobes in a mirror or ask a family member to look. A diagonal crease that runs at approximately 45 degrees from the ear canal toward the outer earlobe edge, as opposed to the horizontal skin fold of a normal earlobe, is the positive finding. Its presence in a senior with other cardiovascular risk factors warrants a proactive cardiac risk conversation with their physician. According to the 2021 Medical News Today review on Frank's sign and heart attack risk, a 2021 study found that people with earlobe creases had low serum levels of the age-suppressing hormone clotho, a hormone associated with premature aging and endothelial dysfunction that may explain the cardiovascular association. According to the PMC case control study on Frank's sign and cardiovascular risk factors, having acute coronary syndrome was independently associated with diagonal earlobe crease with an odds ratio of 5.3, meaning that adults with a diagonal earlobe crease were 5 times more likely to have had an acute coronary event, even after accounting for other risk factors. This does not mean that everyone with an earlobe crease will have a heart attack. It means that the presence of the crease, a simple, visible, no-cost finding, should prompt a more thorough cardiovascular risk assessment conversation rather than no conversation at all. The fact that this observation has been in the medical literature since 1973 and is still not routinely communicated to the public represents a significant gap in preventative cardiovascular health education. Sign number 1. Visible changes in the fingers, nails, eyes, or skin. Specifically, digital clubbing in which the fingertips widen and the nails curve downward to become thicker and more rounded. A blue or purple discoloration of the lips or fingertips called cyanosis. Yellow fatty deposits called xanthomas appearing on the elbows, knees, eyelids, or Achilles tendons. Or a gray-white ring around the outer edge of the iris called arcus senilis. According to CNN's Cardiovascular Signs Overview, digital clubbing may be a sign that all is not well with the heart, with fingernails changing shape and becoming thicker and wider. Yellow fatty bumps known as xanthomas can appear on the elbows, knees, buttocks, or eyelids as a sign of bigger problems including familial hypercholesterolemia, and fat deposits seen as a gray ring around the outside of the iris indicate significant lipid metabolism abnormalities. Cyanosis. The blue discoloration of the lips and fingertips that occurs when oxygenated blood is not reaching the peripheral tissues is a visible sign of cardiac output failure or significant shunting of deoxygenated blood that warrants same-day emergency evaluation when it appears acutely. The combination of any of these visible signs with any other symptom from this list forms a clinical picture that requires proactive cardiac investigation without delay. Xanthomas, the yellow fatty deposits visible on the eyelids, knees, elbows, or Achilles tendons, are particularly significant because they represent an almost certain indicator of very high LDL cholesterol or familial hypercholesterolemia, a genetic condition that dramatically accelerates atherosclerosis. A senior who has had yellowish deposits on their eyelids for years without having had a lipid panel performed has been carrying a visible sign of elevated cardiovascular risk without any of the standard risk reduction treatments that would be initiated by that single blood test. Arcus senilis, the gray-white ring at the outer edge of the iris, is considered normal in adults over 70, but warrants a lipid assessment in any adult under 60 in whom it appears, as it indicates significant lipid deposition in the peripheral cornea from elevated circulating lipids. The most important action any senior can take for their heart health requires no specialist, no imaging, and no lab test at the first step. It requires a conversation with a primary care physician that uses the words, "I would like to discuss my cardiovascular risk and whether any of the signs I am experiencing warrant further cardiac evaluation." That conversation opens the pathway to the ECG, the echocardiogram, the lipid panel, the blood pressure assessment, and the coronary calcium scoring that together provide the complete cardiovascular risk picture. Heart disease is almost always more detectable before a crisis than after one. The 15 signs above are what detection looks like before the crisis arrives. For any senior who recognizes 3 or more signs from this list, or even a single sign that is new, persistent, or concerning, the appropriate response is a physician appointment that specifically frames the visit as a cardiovascular risk evaluation rather than a visit for an individual symptom. Bringing a written list of every sign noticed with approximate dates when each first appeared gives the physician the timeline that transforms individual symptoms into a pattern that guides the correct diagnostic pathway. Coronary artery disease that is identified through risk assessment and imaging before a first event can be treated with medications, lifestyle modifications, and in some cases procedures that prevent the heart attack rather than responding to it. That prevention is available to every senior who recognizes the signs and acts on them. Watch the next video on screen right now.